My name is Thongchai from Siracha Hospital. I'm here today to give you my case presentation about the fracture dislocation of the proximal humerus. Okay, let's start it. 61-year-old Thai lady came to our hospital with a simple fall, with the left shoulder landing on the ground. Okay, and she had, on physical examination, she has a lot of deltoid contour, she had positive Yuga sign, and she had limited range of motion due to pain. No wound was seen externally. Distal neurovascular was intact. The film is shown like this. Okay, it had a comminuted greater tuberosity with the fracture dislocation of proximal humerus. Who will do the cross reduction? Please raise your hand up. Okay, thing is the same. My resident did the cross reduction with the traction and counter traction technique, and she feels sensation about cracking, pop or something like that. And after that, send the patient to make the X-ray on the left shoulder again, and see like this. Okay, we found is the shaft is come into the socket, but the head is still in the same position. Okay, this its head, and we found it still had a comminuted greater tuberosity and additional lesser tuberosity fracture. Okay, I have a review literature about the greater tuberosity fracture has incidence of the iatrogenic fracture about 25%, and the size of the greater tuberosity is a significant, is a bigger size, had a higher incidence. Okay, I will show you the CT 3D to see the overall. We found it's the head anatomical fracture, and still had a greater tuberosity fracture and also had a lesser tuberosity fracture, like this. Okay, for the CT 2D coronal cut, we start from the anterior to the posterior. This is a coracoid. Okay, we will see the video. You see, it had a fracture like this. Head is still in the subcoracoid space. And for the axial cut, from the top to the below, we found the comminuted fracture greater tuberosity. We found the lesser tuberosity fracture, and also we found the head under it. From the sagittal cut, start from the lateral to the medial. The left side of your hand is the anterior. We found the comminuted fracture of the greater tuberosity, lesser tuberosity, and still head inside. The diagnosis in this case is a 4-part fracture dislocation of the proximal humerus. The treatment, I think, had a two way. The first is open reduction and internal fixation, and the second one is a proximal humeral replacement with tuberosity reattachment. I choose the first one. But before the treatment, I want to remind you about the vascular injury that associate with the fracture proximal humerus. From literature review, you need the accurate physical examination, especially about the radial pulse or the ulnar pulse. You need to palpate it before. If you doubtful, you need to send the patient to do the angiography. We choose the internal fixation. We decide patient in the supine position. We choose the deltopectoral approach, and we set fluoroscopy opposite the site of the injury. The fixation technique, I have a special instrument for help for the reduction head like this. Sterile spoon.
This is expensive.
Yes, and after that I will do the suture fixation to fix the greater, lesser, and the infra teres minor. And after that I manipulate with the suture fixation to put the head back inside and put the greater and lesser back and fix the shaft and the head with the KY fixation. But you see, what happened after I put the greater and lesser back. It looked like loss of the pillar. That I need to looking for or find something that to make the pillar for the greater and the lesser. I use iliac bone crest stud graft, 2.5 centimeter in length and 1 centimeter in thickness, and put it inside for make the pillar for the greater and the lesser tuberosity like this, and fix it, and put the press screw inside. After that, and I do it every case for the suture fixation at the plate. This immediate post-operative film, you will see I cannot get the greater tuberosity fragment all of that to back up to the right position. For the 2-month follow-up, the film show like this, and the 3 month, the head still so wide, but the greater tuberosity is had osteolysis. And the 5-month follow-up, it still has osteolysis. That make the patient didn't have a good outcome. We perform on the left side, but the patient still had the frozen shoulder on the right side. The range motion like the picture. At the 5-month follow-up, external rotation around 10 degrees and the internal rotation at the L2 level. Thank you.
Thank you so much for the very interesting case, very complex case, 4-part fractures with the dislocation. I think that we have around 6 minutes for comment from the panelists. May I invite Ajahn Sittiporn first for this complicated case?
For this case, I thought that it's old age and female, 61 years old, and have the 4-part fracture. And the piece is very, very thin. So the fixation is, I thought that it's not so rigid, not rigid. Then I will make a replacement. My first choice, my choice is a replacement rather than fixation.
So
because and another thing that when you follow is have a high incidence of avasculosis also.
Okay. So you think that at this age, the replacement might be gain a good outcome. Okay. Thank you. May I ask Ajahn Thirachai for your comments?
I just made a comment on the diagnosis. Yeah, we have taught from our teachers, if you have this location, what next? Close reduction. Yeah, but be careful. Yeah, if it's just simple dislocation, then it's fine. Try close reduction. But this is complex fracture dislocation. For me, I said, if I have the CT, can be done, I will do the CT first. Or in case you are in doubt, you make a furrow before your reduction. Not do it at the emergency room. This case is not possible. Yeah, make it under furrow and then you try. If you see the fractures, sometimes you see it, then you go to open reduction. Then you fix the head and the shaft first, and then you make reduction. Yeah, you make open reduction. Yeah, this is my point of the diagnosis. It's the same as a femoral head or femoral neck fracture associated with hip dislocation. It's the same. Yeah.
Ajahn Thirachai, just look at the X-ray like this. Do you think this is just a 2-part?
No. I never believe this X-ray. I always tell my resident, take the best X-ray you can for this type of fractures. This position. Normally, the patient was in this position, right? And you cannot see anything. And they said, oh, it should be this one, this one, this one. It's wrong. Yeah, make a good X-ray, and in some case, you need a CT.
The reason I ask is that I think it's not uncommon to see the 2-part greater tuberosity fracture dislocation of the shoulder. So do you mean that you suggest that 2-part greater tuberosity, you suggest CT scan in every case?
In this case, it's not 2-part. You see, if I look here, this is a GT, right?
Yes.
You have one piece, you have another one piece here. Yeah, and you see, this is something, maybe. That's why I said, be careful.
This is very difficult. If normally we don't have this clear picture, and sometimes we cannot see. Ajahn Kanyika, would you please?
I think this from this X-ray, the humeral head is not normal relationship with the humeral shaft. So it's quite clear that this should have something between the head and the shaft. However, I think at present there's many authors that recommend that we should do CT scan in every case because some is just the hairline fracture, and when you reduce the dislocation, especially not in the operating room but in the ER, it must have much force to do. So the displacement will occur.
Okay. So I think this is very important point as this kind of X-ray is many times it's not that clear that we can rule out fracture, crack or not. May I ask in this room, you can raise your hand. We have listened to the panelists. Who will choose in this kind of fracture greater tuberosity with dislocation and not sure about? Will you do CT scan before reduction? Please raise your hand. 1, 2, 3, 4, 5, 6, 7. I can see 2/3. I don't know, right or wrong, but the panelists seems like agree. You agree. So this is what I may conclude in this case at the beginning, that fracture dislocation with greater tuberosity, you have to think about CT scan before reduction, emergency, right? Send to the CT room and then come back and see what you will do. Otherwise, you have this problem and medical legal issue comes. Ajahn Apipop, you have some comment. We have limited time, maybe only one comment, and have Ajahn Manchong. Just very fast comment.
Another option is, I think, you just bring the patient to operation theater and close reduction under full fluoroscope imaging. Or if you can see the fracture at the surgical neck, it's non-displayed, right? So you just temporarily fix with the KY, and then you can do close reductions. That's another choice, I think.
In my practice, usually, although they have a fracture of the greater tuberosity, for the elderly patient, especially for the osteoporotic bone, normally we will reduce under the condition that patient feel comfortable and relaxed without any pain. Otherwise, you have to push a lot of force for reduction. And I would suggest traction, counter traction is safest technique. Don't use the reverse mechanism technique. Otherwise, it will create some iatrogenic fracture of the neck like this. And to consider, even it is a 2 or 3 part fracture, it should be considered after reduction already, not just before reduction. That is my point.